This is a post-progression treatment analysis of the Evera breast cancer, BC. This is a phase 3 trial of giredestrant and everolimus in patients with estrogen receptor positive advanced disease who have been previously treated with a CDK4/6 inhibitor. So first, to set the stage for our discussion, I would like us to focus on two key pathways. And those are the estrogen pathway and PI3K AKT mTOR pathway. And those are crucial in the development of resistance in the hormone receptor positive advanced breast cancer subset. And by using giredestrant and everolimus together, we are targeting those two major resistance mechanisms. So the trial, as we mentioned earlier, is a phase 3 trial that looked at patients with metastatic hormone receptor positive breast cancer. They could have received up to 2 prior lines of endocrine therapy, and they developed progressive disease or relapse during or post CDK4/6 inhibitor plus endocrine therapy. Nobody received any chemotherapy in the advanced setting on this trial, and the patients were randomized in a 1-to-1 fashion to either receiving giredestrant at 30 milligrams daily plus everolimus versus standard of care endocrine therapy, which could have included exemestane, fulvestrant, or tamoxifen plus everolimus. And previously, we've seen positive results with the investigator assessed PFS in the ESR1 mutated tumors and in the overall study. And what was reviewed in ASCO of this year was the exploratory endpoints of PFS2, chemotherapy-free survival, post-progression treatment, and also an interim analysis for overall survival. So as a refresher for the previously reviewed baseline demographics, I would like to focus on a few things here. This is a trial that was significantly enriched with the ESR1 mutated population. So we can see that more than 55% of patients had ESR1 on both arms. There was also a significant representation of a major resistance mechanism, which is the PAM pathway alteration, more than 40% of patients on either arm. Definitely the most common mutation was PIK3CA, but then we've seen also a decent representation of AKT and PTEN. Also, about half of the patients on both arms did receive prior fulvestrant. So the previously reported results in the prior conferences, we've seen here that the investigator-assessed PFS was significantly improved in the ESR1 mutant population from a baseline of median 5.4 months to almost 10 months with a hazard ratio of 0.38. But also in the ITT population, there was a benefit with an improvement from 5.5 months to 8.7 months with a hazard ratio of 0.56. However, when they underwent an exploratory analysis, it showed that most of the benefit really was being driven by the ESR1 mutant population. So here you can see the 5.5 to 10 months. And when you look at the ESR1 wild type, you can see practically no difference. So this is really important to keep in mind. Also, when they looked at patients with an ESR1 mutation and compared the population that had the co-expression of a PAM pathway alteration with the ESR1 mutation, there was absolutely no difference on both sides. So that is quite reassuring and very important for this difficult to treat subset of patients. Now, for the AEs and toxicity, previously they reviewed no unexpected side effects really from the combination, and a lot of it has to do with inclusion of everolimus in treatment. So stomatitis, diarrhea, fatigue, and pneumonitis were almost equal on either side. And when we look at side effects like bradycardia, which has to do with giredestrant, most of it was asymptomatic or grade 1. The degree of discontinuation, which is always something that I look at in trials to see how well were patients able to continue on with the treatment protocol, you can see that it is not remarkably different, even though, of course, in the combination arm, it was slightly higher at 17%. Now, we've seen here that PFS2 in the overall study in the ESR1 mutant and in the ESR1 not detected population did show an improvement of 31%, 39%, and 23%, respectively, in the three subsets. The median PFS2 was 19 months in the overall study and the ESR1 mutant, and about 17 months in the ESR1 not detected population. The chemotherapy-free survival, also in the three different subsets, so overall study, ESR1 mutant and ESR1 not detected, was improved with 39%, 54%, and 20% respectively, with a median of 11 to 12 months in the overall and ESR1 mutant and 9.5 months in the ESR1 not detected population. Now, at this time of the interim OS analysis, it looked like it's moving in a favorable direction, which is consistent with what we have seen in terms of progression with PFS2 and chemotherapy-free survival. But I want to share with you that the OS was not evaluable in the giredestrant and the everolimus arms across the three different subsets. And one important thing to pay attention to is after the patients progressed, what kind of treatments did they receive? And as expected, chemotherapy was the most common subsequent treatment, followed by endocrine therapy, with or without targeted therapies, and about a quarter of the patients did receive ADCs. So overall, it was well balanced between the different subsets, and it also reflects that some patients could have received more than one line of subsequent treatment. So in summary, I think we can take home that giredestrant and everolimus showed a sustained PFS benefit through the next subsequent line of therapy, with an improvement in PFS2 and chemotherapy-free survival. We've seen that the subsequent therapies were generally balanced across treatment arms, and they are representative of the current standard of care. And PFS2 and chemotherapy-free survival were consistent with a favorable OS data at the time of interim OS analysis.
In the evERA data, the PFS and the response rate didn't really match. It looked like the PFS was superior only in the mutant patient population, but the response rate seemed to be superior in both. Any thoughts on why that is the case, and would that change how you would want to use giredestrant in the future?
I guess I did not have a clear explanation as to why that happened, but the primary endpoint of the trial was PFS, and probably that is how I will focus on interpreting those data. I was so underwhelmed by the ESR1 wild-type population, and that is why I strongly believe that really is only active in the ESR1 mutant population.